it's such an important topic. Thank you so much for raising it. And it's the kind of thing you just hope and believe that there's going to be someone there for you when you need them. And we need to make sure that's a reality in rural communities across the country. And so what we in the Biden-Harris administration have been investing in is two critical things. One is training more providers. We need more people to become healthcare professionals, and people want to do it, but sometimes need a little help to be able to do that. And so we offer scholarships, we offer loan repayment programs, we offer stipends, we offer a host of things to try to make it easier to get through med school, get through residency training, and then practice in a rural community.
Hello, and welcome back to The Rural Impact, a podcast that works to connect the dots from policy to rural everything. If this happens to be the first time you've heard my sound of my voice, I'm Michelle Rathman, and thank you so much for being here. For those following along, or in case you've missed the first part of this episode, here's a recap. I had 5 conversations with 5 different experts on 5 different high-priority rural health-related subjects, policy and legislative matters to be specific. We talked about everything from Medicaid expansion to maternal health, veterans care, workforce solutions, and of course, we did also expand the conversation about aging in place with dignity and with access to services for our rural adults. So with that said, I don't think there's any time like the present to get started on part 2 of this Policy on the Road discussion, shall we? With that said, next up on the agenda, I can't wait for you to hear my conversations with these 4 new experts. And starting us off is a guest who also kicked off this podcast nearly a year ago during our Rural Health on Life Support series. And that is Mr. Alan Morgan. Alan is the Chief Executive Officer of the National Rural Health Association. He's a very busy individual, so I'm grateful that he took some time during this conference to sit down and chat with me for a bit. And for this discussion, Alan could speak to subjects from A to Z where this is concerned. But for this discussion, I asked him to speak about really the state of rural health in the context of emergency preparedness. And that includes rural health systems, their ability to protect themselves and patients from cybersecurity threats, which is really, I've been saying, the kiss of death for rural health systems. We need not imagine cyber threats to healthcare because we're bearing witness to its gripping effects right now, almost every day in the headlines. And we do know that some rural hospitals have been brought to their knees as a result. And because we do know that it's not a matter of if, but rather when the next crisis will take place, where access to emergency and essential health services are going to be dire and needed in rural places. For that and many other reasons, I invite you to listen to my conversation for some insight about where we are on this issue in the context of emergency preparedness, where rural health is concerned. Here now is Alan Morgan.
Okay, continuing our fantastic conversations from my favorite conference of the year, which is the National Rural Health Association Policy Institute, because this podcast is all about connecting the dots between policy and rural everything. And I cannot tell you how thrilled I am to have the man himself, Alan Morgan, as the president of the CEO of the National Rural Health Association. I had to get that right. Give credit where credit is due, joining us. I have a binder next to me filled with your policy priorities. And I've been talking with different people about different things. And I thought one of the things that you and I could talk about, you've said this is like your 20th or 28th? 24th. This is like my 12th or something. Mm-hmm. And National Rural Health Association was really, in so many ways, on the front line during the pandemic. And you are here supporting, advancing policy and advocacy work that helps our rural health systems build capacity. And I wanted to talk to you a little bit today about the emergency preparedness, because as we are seeing rural communities in particular, the effects of climate change, hurricanes, potential for tsunamis, public health crisis. Talk to us a little bit about where are we today in comparison to where we were before COVID? What lessons have we learned? And then we'll go from there.
Yeah, so much has changed, and unfortunately not all for the good since the beginning of this. And Michelle, you and I have talked before at the onset of COVID, from the federal official standpoint, they were constantly asking, why is there not capacity in a rural setting? Why do we not have the beds? Why do we not have the workforce? Why not have the supplies? And we went through 2.5 years of those discussions. And then the first thing out of that, the federal government announced a new rural emergency hospital program, which eliminates inpatient beds. Now, that's a great opportunity to keep emergency room services in rural. But again, it goes right to the counter of all that we had just gone through for the last 3 years.
It's one component. So one of the things I struggled with is that it doesn't provide for primary care. And as we've been talking about maternity care deserts and so forth. So let me ask you this. What do you think, for the rural hospitals and rural health clinics and other partners, FQACs and so forth, how are we prepared to handle what's next? Because we know there will be what's next. With all these challenges before us, what are some of the things that National Health Association and your advocates are working to advance, our members of Congress and our lawmakers, to say, these are some provisions that we really need you to bake in to your funding?
Such a good question. Well, what we already knew and what was displayed is we have a lack of access to capital in a rural concept. We have workforce shortages in a rural concept. But what we do have is this creativity when it comes to innovative healthcare delivery, right? And so in the heart of COVID, what we learned is we have to let professionals practice to the top of their license, and including community health workers, nurse practitioners, physician assistants. How do we practice in a team-based approach? And really, rural America led the way on that. Facing challenges, team-based approach, and being able to ensure they can deliver care. I think that is the one lesson we did learn and we're going to carry forward. But you still have this lagging issue of workforce, which we have to get a handle on. There has to be a greater expansion of telehealth and integrating that into the delivery model. You talked about that quite a bit in the past.
We did it during as a provision during the pandemic. And it just seems to me that we're running around like with a fire hose, if you will, instead of building the infrastructure and the payment models that support it.
Yeah, it's so true. And I want to go back to this also, Michelle, this concept of access to capital. If any facility wants to improve their delivery system, you need that. If you're going to expand your chronic care management, you need that. And one thing that came up during our policy congress last night, where you were engaged in with us, is this concept of cybersecurity.
Yes.
And so many right now, we know we have a problem. We've heard that so many of our members have faced ransomware attacks. But where is this capital that these facilities need to harden their system? And I think that is a discussion that just hasn't hit the forefront like it should yet.
Yeah. And what was the number that we heard this morning? Like cyber attacks up like 278%.
Ridiculous amount.
And you've seen me post this. A cyber attack is the kiss of death for a rural hospital. And you've seen some
absolutely
have to shut their doors as a result, because it's not just the protection in advance, it's what kind of protection to help them recover.
And I think we talk about this. We know it's an issue, and it's so timely. Just a week and a half ago, when the head of the FBI announced that there are threats to our infrastructure. Well, healthcare is an infrastructure. And so I think we're going to see a lot more focus on that, obviously, in the coming months than we have in the past.
All right, I have one last question for you, Ellen. And this one, and I'm being curious to ask this of everyone I'm talking to in our special episodes that we're doing focused on health and policy. We're here, how many are registered? The work that we do here is very important, but it certainly is not the end of the road. And so what would you say to rural health leaders and community leaders? Because we have to include, as you and I were talking this morning, our county, our city managers, our schools. We need to get them into the fold. So what would you say would be a few pieces of advice for us to take and then teach what the advocate's toolkit looks like? Because we can't, you say your voice only louder, but we have to get louder.
Absolutely. Just become a resource to your policy leaders. Lawmakers and policymakers, they want to hear from you. How does this affect our small town? And whether you work in a community health center, whether you're working in the hospital, the clinic, make sure that you made that contact with your local official, state, and federal official and say, I'm here if you have any questions healthcare related. I can tell you how these policies will impact on the ground in our community. That's really what they want to hear. There's no greater way to impact national policy than to just tell your story on a local level. And you can't preach that enough. And it's always surprising. You and I have talked about this, how much of an impact an individual can make when they're able to say, in my small town, here's what your policy is going to be. And that translation is worth its weight in gold.
Our thanks to Alan Morgan. Again, such a very busy individual doing some amazing work. And I'm so appreciative that he sat down with us at the conference and had that conversation. And I'm going to just say I'm glad that Ellen and I were able to wrap up our conversation on an advocacy note, including the importance of storytelling. If I've learned nothing, it is one of the most I call it a power tool. And it really is the perfect segue for our next conversation. Back on over, I went to the National Association of Community Health Centers Policy and Issues meeting, and I'm joined by Susan Burton. You'll hear from Susan. She is the director of National Grassroots, and she and I covered so much territory. I wish you could have heard the entire conversation, but I'm glad to share a piece of that with you today, including the fact that we talked about the critical role federally qualified health centers, known as FQHCs, play in rural communities, how and why they exist, and very importantly, why funding to CHCs are lifelines to care for millions of rural and under-resourced populations, offering a breadth of wraparound services. I call it the outer layer of needs for patients and communities. In so many of these cases where other resources may have moved on or closed their doors, it's just simply not feasible. Community health centers are the only game in town, if you will, and this includes for dental health. And it's not a subject that I think that we're talking about enough. And I really believe that we should, because dental health is directly related to our physical well-being over time. So with that said, here now is my conversation with the ever-passionate Susan Burton.
Thank you so much, Michelle, for having me. I really appreciate this opportunity. So federally qualified health centers, FQHCs, we also talk about them as community health centers. Mm-hmm. The community is really important because 51% of the board members of community health centers have to be patients at a health center by law. So it means that in every single community that you go to, you're going to find a community health center that reflects the community that it's serving. So the services that are provided are going to be based on what the community wants and needs. It's a very unique model of healthcare. It's exciting to me because it does, in my experience visiting health centers across the country, the people who are serving the community, live in the community, respect the community, honor the community. And so no matter who you are, when you enter a health center, you're going to be seen as a person of sacred worth. I'm a person of faith. And so for me, that really matters. You're going to be seen as someone who has inherent dignity. And so you're not going to have to explain why you matter. And I think sometimes people are concerned about going to get healthcare because they're not sure someone will judge them or love them, right? Because there are different ways that people have experienced healthcare. When I think about community health centers, first of all, we talk about them as a healthcare home. Not only do you get primary care when you go into these places, right, into health centers, but you're also, if you are struggling with mental health issue, depression, if you have a child who has a learning disability, if you have a high A1C, right, and have diabetes, they're going to talk with you about medication potentially and exercise, the things that providers talk with you about, right? They're also going to connect you with a dietitian in-house. They're going to hand you off the warm touch so that you've got everything under one roof or nearby, right? Providers know one another. And so when the care team sits down to talk about your case, they're going to begin identifying resources that can support you. And I love it. I mean, we talk about rural communities.
Right.
My first year when I worked here at the National Association of Community Health Centers, I met a woman who worked at a health center in Western Tennessee. And she talked about how little transportation there was in her area. And that one of the things that they did to make the health center accessible to patients was to have vans so they could pick patients up.
Yes.
Right? Because I think sometimes we take public transportation for granted. I think we take for granted that everyone has access to a vehicle and can get to their appointments. And we also forget that people have to make choices about where they spend their money. Am I spending on medication or groceries or gasoline or rent?
We know that critical access hospitals and rural health clinics, different than community health centers in rural communities, they have a certain payment model. but community health centers have a very different formula. So how are community health centers paid? And let's talk a little bit about the patient's obligation.
Right. So what's really important about health centers is that we, in addition to the 51% board members by law, we also have to care for people no matter their ability to pay.
Mm-hmm.
So health centers will have oftentimes people that are uninsured come, and there's a sliding fee scale. So you pay what you're able to pay, which means that it's going to be more accessible, right? If you have Medicaid, you can go and then you'll be able to be seen as well. And if you have private insurance. So health centers serve everyone. And that's one of the great things. And I think the other thing, I was one of the board members here, community board members of a health center in rural North Carolina, said I was a patient at a health center when I had no insurance, when I had Medicaid, and then when I had insurance. And I was treated the same way with every type of insurance, the whole way through. That there really is, the focus is on the patient. The reimbursement, having Medicaid and having people with insurance helps because then the services are reimbursed, right? If health centers are caring for people that don't have any insurance at all or uninsured, then they're not reimbursed for their services. And so there are other ways. There's a 340B program, which is a pharmaceutical discount program that allows health centers to reinvest the savings into the community health centers.
Which is similar for a critical access hospital.
It is.
So let's dial in on what some of these important dates coming up here, because we dodged a bullet in January.
Yes.
And I really hate to use that term, but honestly, that's the way it feels. And now we've got this other date coming up. The day that we're recording this, it happens to be on Valentine's Day. So show us the love, Congress.
Right.
What is it that the National Association of Community Health Centers is asking Congress to do?
So you named it. 31 plus million patients are served around the country through community health centers. And 1 in 7 live in rural communities.
1 in 7.
And 41% of health center patients are in rural communities. That's a lot of people.
Yes.
Who could lose care.
Especially
in
when we have
services.
hospital closures.
Right.
So you are the truest form of a safety net.
Absolutely. Absolutely. And I think, sometimes safety nets can have a derogatory,
yes,
right? But we're talking about working folks who are working hard and don't have insurance because their company doesn't provide it. Right. Their company doesn't provide it. Or people earning a little bit too much money to qualify for the marketplace subsidies, right? So there are all kinds of ways. We forget that there are people across the spectrum in terms of income and responsibilities and ability to get access insurance. A lot more people are insured now than were before. Still, the other thing is health centers are often the only providers in a community. Only providers, only pharmacy within hundreds of miles, right? And so I think that what's on the line is the health center funding. In the past, we've had most recent, we had a 3-year and a base grant, which is, again, 3 years matters because it means that a health center can contract with a pharmacist, can contract with a clinician for that period of time and knows that they're going to be able to pay them. And so the provider, any number of those care teams, whether it's a psychologist, dentist, social worker, whomever it is, a dental hygienist. There's some communities where they cannot find dental hygienists, right? And so if they have this 3 years, they know they've got that money that they can then sign a contract and definitely pay folks. So that's 70% of the funding that comes from Congress. The other 30% is passed year to year, the annual spending, the discretionary funding.
Okay.
Right. So there's mandatory and discretionary, long-term, short-term, long-term, annual. All of that expires March 8th.
March 8th.
So what that means is if this funding doesn't get passed, that means that health centers are going to have to start, and some are already thinking about layoffs. And again, this means not only that you're losing a provider right now, but you could be losing a provider forever if you're in a community where it's hard to recruit and retain.
Again, I want to thank Susan Burton for joining me at the table. It was our first time that we had a chance to talk, and honestly, she exudes such passion for the work that she does. And I really would like to invite you to reach out to the National Association of Community Health Centers. Know if you've got one in your community. And as a piece of this, Susan did talk quite a bit about how important it was for community members to tell their stories, as you heard from a previous conversation with Gerard Jolly from the same organization. Okay, so we just talked a little bit about the legislative mandates, the FQAC boards. Some of that conversation focused on that, and that 51% of their boards are represented by communities. And similarly, critical access hospital boards, those that are not system owned, also rely on community members to sit on their boards. And you might be wondering, what does this have to do with policy? So I'll tell you in just a moment. Unlike community health centers, there's no requirement to be a patient. However, make no mistake, rural hospital is only as strong as its leaders, and that includes its boards. And boards are very important when it comes to advocating for the resources that their hospital and health systems and health centers need. And that's why at this particular time, I invited, kind of like a build here, I invited a top expert in this area to share some of his insights on the subject of governing boards and the important role that they play in making sure that rural hospitals are represented. And that expert is Mr. Brock Slabach. And Brock is the Chief Operations Officer of the National Rural Health Association and himself serves on many boards and in fact does a great deal of work in the area of board education. And that includes members being informed about the policy matters, as I said, that impact their organization's solvency. Maybe that sounds like a strong word to use, but it really is the reality today. It's important for them to understand these things because it helps them with their ability to navigate the policies, the regulations, and conditions causing rural hospitals to slip into that category, the undesirable category of vulnerability. Before shifting the conversation to the policies that are making a big impact on rural health here, now is my conversation about the importance of local leadership on these heavy-duty national policy issues.
Well, I think maybe to start the conversation, talk a little bit about the complex environment that hospitals are facing right now. Peter Drucker, decades ago now, said that hospitals are perhaps one of the most complex organizations in the world to operate. And part of that is because there's that board, medical staff, and administration relationship that is interrelated. It's like a three-legged stool. And if one leg is out of balance with the other, it really causes it to be unstable as a sitting device. And, I see all over the country in rural facilities where that three-legged stool is really not at all stable. And some of it goes back generations. I mean, this isn't something that may have just happened yesterday. It's systemic. Okay. And so we try to deal with those. And some of the areas that I work in terms of the roles that I play with rural hospitals, is helping to try to understand some of those dynamics and maybe intervene in a way that can be helpful.
So we've had quite a bit of turnover. And, I think we'd be kidding ourselves if we didn't understand that some of this was driven by the pandemic because the stress just became too much for people.
Right.
A lot of the CEOs I talk to, their boards are really pressuring them to have a plan B. What happens when you hand the baton at somebody else? Let's talk a little bit about that and the things that our NRHA is doing to help fortify leadership and get more people into the fold.
Well, I think we're involved in a couple of different initiatives. First of all, we have our Leadership Academy, and we run a CEO certification program that helps individuals that may have experience in administration or may not get sensitized to the issues of rural, because it is different.
What would you say, Brock, are the characteristics of a high-performing community health board?
So I would go back to the basics. So every time I talk about board and their role is the duty of care, the duty of loyalty, and the duty of obedience. And if you learn nothing in terms of your role as a board member, but understand those three things, I think everything else kind of falls into place. The board is only speaking through its actions when it's together in total.
Yes.
And so there's no individual person on a board that can act alone. And so when you understand you're working within a system, when you're working within a structure, and that your role is to be basically a caretaker of the organization, because you're hoping to hand it off to somebody next as an organizational transition. So you need to make sure you're doing those things that are important.
Sure, yeah. So the last question I have for you, and if you try to take a stab at this one, because I don't see any time in the near future where we will not need community members to serve. So any of our listeners are thinking,
Yeah.
hey, maybe I'll run, or if your county commissioners appoint you, what would you say are the qualities that are the best board member, if you will, the best makeup of the board? You don't have to have healthcare experience, but what are some of the things that you
Right.
think are a given? Like, first of all, I think one of them is have good intentions.
Yeah.
But what are some of the things that you could say in case someone's thinking, maybe I'll run for my hospital board?
Well, I first of all would encourage anybody that feels so inclined to do that. I look at these kinds of efforts as being a community-minded passion. So if you have that passion for community, for helping your neighbors in terms of making sure that they're accessing healthcare in a quality and a safe manner, and that you as a board member are going to be participating in that effort to serve the people that you live with, you go to church with, you engage with every day, see them in the store, see them in, the post office. Those are the kinds of relationships that are being built that I think make you an extremely good board member. Because you're really reflecting or representing the community when you're on this board. What are the values of that? And that's why I think that I have nothing against systems, but that's why I think that all healthcare is local. And you need that community representation to be able to tailor the community services that you're providing in such a way that it meets the needs of the community. And who could do that better but people from that area, from that community to make that happen?
Yeah, I appreciate that. And once you do, the importance of participating in conferences like this, I wish we should see more board members at these events, because understanding policy, I mean, they have the absolute skin in the games when it comes to that. So being really, there's no lack of information.
Well, I will say that board member advocacy is incredibly powerful. Congress, members of Congress and in the Senate, they really respond to board members.
Oh, really?
Because they look at management, people like me who are hospital administrators, as being kind of the hired hand.
Oh, right.
Board members are people who represent the community. They're volunteers. And their advocacy, your advocacy, can be extremely powerful when you call and say, hey, look, your 2% sequestration is really impacting our ability to keep our doors open. That means a lot to Congress. That goes a long way. They expect the administrator to say that. They're not so much inclined to hear volunteers say that.
Thanks again to Brock for joining us. I really do appreciate his insights and think that the local governance piece is just another very important dot to connect to this bigger puzzle that we have. And of course, you've just heard excerpts from 8 of many conversations I had from D.C. last month, and I've saved one very special one to close out this special On Location episode. You've heard me say it often, but in case you have not, it's worth repeating, and that is the road to quality of life is indeed paved by policy. And it's one thing to have proposed legislation, but really it's quite another when laws are signed, agencies are mobilized, and the resources start to make their way into the rural counties people listening here call home, and that includes you. So it is my pleasure to share with you the conversation I had with HRSA Administrator Carole Johnson about the Biden-Harris administration's investments in America's rural health. And that includes its infrastructure, its workforce, and the programs that address the maternal health crisis, long-term care, and other challenges facing us today. So here now is my conversation with HRSA Administrator Carole Johnson, just after she delivered her keynote remarks at NRHA's Rural Health Policy Institute.
It's such an important topic. Thank you so much for raising it. And it's the kind of thing you just hope and believe that there's going to be someone there for you when you need them. And we need to make sure that's a reality in rural communities across the country. And so what we in the Biden-Harris administration have been investing in is 2 critical things. One is training more providers. We need more people to become healthcare professionals, and people want to do it, but sometimes need a little help to be able to do that. And so we offer scholarships, we offer loan repayment programs, we offer stipends, we offer a host of things to try to make it easier to get through med school, get through residency training, and then practice in a rural community. I had the good fortune recently of visiting one of our rural residency, we call it our Teaching Health Center program, where every resident in the room, all of these young physicians, were from rural communities.
That's so important.
And they all trained in a rural community. And every one of them around the table said what they wanted to do was practice in their hometown or in another rural community. That's what we need more of. And that's what we're investing in. More rural programs to get people trained. It's sometimes we call it grow your own.
Yes.
Like people want to do this. We just need to give them a path to do it and help people know that there is a path to do it.
Yeah. And especially where we're talking about not just primary care, but and the next thing I want to talk to you about, obviously, is maternity care.
Right.
And you recently joined my former Congresswoman, Lauren Underwood. I was kind of redistricted out, but I was on her health advisory council. And we know that she has been so instrumental in advancing the discussion and bipartisan policy support for programs that help us address this growing, really, it's risen to a crisis level. So let's just talk a little bit about the initiative to improve maternal health and outcomes, and what are some of the things that HRSA is doing to help us address that?
Let me tell you 2 facts to help frame this issue for people who may not know as much about it. When we started in the Biden administration, there were 2 things that we knew were true. The United States of America has one of the worst maternal mortality numbers in the developed world.
It's so painful.
2, 80% of maternal deaths are preventable. So that means there is a ton of room for action. And what we've been laser focused on is action. How do we change that dynamic? We know that some of those leading causes of death are mental health conditions, they're cardiovascular conditions, things like hypertension, preeclampsia. They're not listening to women's voices when they tell you what's happening in their experience in the clinical setting. They're the bad outcomes that are happening the year after delivery, not just that first 30 days, but the months after delivery. And so we're changing that trajectory. We've expanded Medicaid for 365 days postpartum. For too many people, we were just dropping them after a short period of time. And so you need to have healthcare. But what we know in rural America is an insurance card is only as good as having a place to use it.
That's right.
So we've also been investing in the workforce to be able to provide those healthcare services, those supports, that follow-up care. That's nurse practitioners, that's nurse midwives, that's doulas. That is thinking holistically. It's your OBGYN plus. It's that real wraparound set of services. And then we just have to recognize that good health outcomes for newborns is dependent on a good, healthy mom.
Right.
And that is what breaks my heart is often moms who have bad outcomes or terrible experiences. They tell their stories and they say, but I did everything right. And we have failed those women if they feel like it's their fault and their burden, when it's actually we haven't built a system around them that does everything right. So that's our goal.
That's a great point.
Build it right so that the best choice for you and your baby is the easy choice. It's easy to get to prenatal care. We recognize that sometimes transportation is a barrier. Sometimes food is a barrier. Good nutrition. Sometimes childcare for your other children.
Right.
So thinking holistically, we invest in a host of programs to try to do that wraparound so that mom and baby have the best possible chance at the best, strongest outcome. And that's what we're committed to. The president is leading in hard on this. It's not just us in the Department of Health and Human Services. You might be surprised to learn. I went to the first ever cabinet meeting on maternal mortality. The vice president hosted it. I sat across the table from the Secretary of Labor.
Wow.
And next to the Secretary of Housing, because the president and the vice president know you have to do all these things right in order to be able to support new families.
So talk to us a little bit about some of what HRSA is doing to increase access to healthcare services, because we know we've got hospitals closing. Not a good situation. We've got some things that we're, trying to do to work around that, rural emergency hospitals and so forth. But can you be a little specific about some of the things that are happening to make sure that we don't see those gaps widening, that we close some of those?
That's right. So part of what we're focused on is, one, we fund what we call the Community Health Center Network. Community health centers are in rural communities and in historically underserved urban communities. They serve 30 million people across this country, providing primary care services, regardless of individuals' ability to pay.
Right.
And so a health center can be an anchor in a community for getting primary care and for getting referred and connected to specialty care when you need it. We also work closely with rural health clinics. We also work closely with rural hospitals, critical access hospitals, to make sure that everyone who's eligible can participate in our National Health Service Corps program,
Yes.
which is how they can recruit providers into your rural community, and we'll pay that provider's medical school debt in return for them serving in a high-need rural community. Sometimes we'll pay scholarships and then they have a service obligation associated with the scholarship. We're trying to say there's lots of ways we can incentivize people to practice in rural communities while we also invest in healthcare providers who want to practice in rural communities from the jump. And so we can do stipends and scholarships and other support for people to get trained up to be healthcare providers.
And so much of what you talk about, all the programs that are available, somehow they need to be navigated. And I guess the next place I want to go to is just there's so much technical assistance that you offer, but a community has to have the capacity. And so let's just talk a little bit about the technical assistance that you provide and how is that playing a role in helping them kind of scale up to even receive those dollars?
Yeah. Well, one, I wish that the resources were at the level that we didn't have to run competitions, but we do because we have limited resources,
right?
And we need people to be able to do that. But being able to be competitive is really about telling your story and having your data to say, this is what's happening in my community, and here's how HRSA's money, federal money, can help change the trajectory. And we've seen it time and time again. It makes a huge difference. But what I found when I started in this role was that when sometimes our applications asked for more information than we needed, they were a little hard to navigate. You kind of had to have done one to know how to fill out the next one. We're committed to changing that. We're committed to making it easier to get in our front door. We're committed to doing tons of resources and support in communities, webinars, technical assistance, grant writing support, like really figuring out how to make it easier for people to come in our front door and get the help that they need. There's certain things about the federal budget process and the grants process we can't change, but everything we can to make it easier to get in the front door, we're going to keep focusing on that.
Okay, lastly, if you could just kind of project out, what are some of the other priorities that we should be looking for in helping our listeners understand that when people think about how is the federal government helping me and my community? So what are some of the things? I know cybersecurity is something that all the agencies are looking at, because I say a cyber threat is the kiss of death for a rural hospital. So what are some of the priorities that you could talk to us about?
I'll tell you, laser focus in this administration on making prescription drugs more affordable.
Yeah.
Your listeners know that is a number one key, both a health impact and economic impact on families across this country. That's why the president's led the fight to get Medicare the capacity to negotiate prices, and why we're making real progress on getting drug price negotiation into the Medicare program so that your drugs are more affordable. And that is essential. So much of healthcare now is about making sure you have the right medication to manage your condition. And so we need to make it so that access and affordability is central to that. And that's what we're committed to.
My sincere thanks to Administrator Johnson for her time. I want to just make sure that I thank her staff, as well as for those at the National Rural Health Association Policy Institute who arranged for us to sit down and have that conversation. It was just really great to hear from her. And again, I really appreciate her time. And you did it. I appreciate your time. You stuck with us. And I want to thank all of our listeners for taking an interest in these conversations. We know, I say it, they're not light subjects. And we hope that during this pivotal time that you take an interest in connecting the dots between policy and how it impacts you and your rural community. It can be easy to kind of like doom scroll or stay really close to the outlets that you look at for your news and information. But when it comes to rural health policy, really, I encourage you to go to the sources and the people who are really following legislation as it moves its way very slowly through Congress. But you should feel confident knowing that there are thousands and thousands of people, both at the state, local, and federal level, who are working to advocate for rural health policy that is equitable and to make sure that it continues to be a place where you can thrive because you have the health resources that you need. All right. And before we sign off, a huge thank you. I'm going to kind of go local now. A huge thank you to Bria Corsaro for all of her work here as associate producer of The Real Impact. To Sarah Staub, thank you so much for All of your graphics and your editing makes everything I do here look so much better. Again, my thanks to Jonah Mancina for our original music. It makes me happy every time I hear it. Of course, to Whipley again for their partnership, for underwriting episodes that focus on rural health. And as promised, we have a whole new series coming your way. And I'm just going to tone it down by saying it is some powerful conversations about rural homelessness and housing. And we'd be so grateful if you would join us again for these conversations on the rural impact. Until then, check your voter registration, and we'll see you again soon on a new episode. Take good care.